Welcome to this practical guide on dynamic pelvic floor MRI. Physical exams often underestimate multi-compartment prolapse and miss posterior cul-de-sac hernias, leading to high recurrence rates if the primary mechanism is misdiagnosed. Dynamic MRI provides a non-invasive, radiation-free solution with simultaneous 3D visualization, dynamic high soft tissue resolution, and evaluation of all three compartments at once. The pelvic floor architecture is divided into three compartments: anterior, middle, and posterior. Each contains specific organs and is supported by key structures, which dynamic MRI can effectively evaluate. The puborectalis muscle acts as the engine of the pelvic floor. It maintains a constant state of contraction to kink the anorectal junction, which is essential for continence. The dynamic protocol involves 4 steps: rest for baseline assessment, squeeze or Kegel to check puborectalis responsiveness, strain or Valsalva to evaluate relaxation and descent, and defecation, which is the critical diagnostic window. Patient coaching is essential for diagnostic quality, ensuring the patient pushes out the gel quickly. In a normal dynamic cycle, the anorectal angle is between 104 and 127 degrees at rest. It decreases by 15 to 35 degrees during squeeze and widens by 15 to 20 degrees during defecation to allow for evacuation. 3 key measurement lines are used to quantify pelvic floor prolapse. The pubococcygeal line, or PCL, is a fixed anatomical baseline. The H line, or hiatal dimension, measures the anteroposterior width of the levator hiatus. The M line, or muscular descent, measures vertical descent from the PCL. This image illustrates the PCL in red, the H line in green, and the M line in yellow, demonstrating their relationship to the pelvic floor structures. Pelvic floor relaxation is assessed using the hammock concept. Normal H and M lines are less than 6 centimeters and 2 centimeters respectively. Increasing measurements indicate degrees of pelvic floor laxity, graded from mild to severe. Anterior pathology includes cystocele and hypermobility, graded by the rule of threes, based on descent below the PCL. Mild prolapse is 1 to 3 centimeters, moderate is 3 to 6 centimeters, and severe is greater than 6 centimeters below the PCL. Middle pathology includes uterine and vaginal vault prolapse. The descent is measured perpendicularly from the PCL to the anterior inferior cervical lip or vaginal apex. A clinical warning notes that large fibroids may mask the true degree of prolapse. Cul-de-sac hernias are hidden pathologies often missed on physical exams, requiring dynamic MRI. They include enterocele, containing small bowel loops, and peritoneocele, containing peritoneal fat. The unmasking effect means these hernias are often only visible at the very end of evacuation when the rectum empties. Posterior pathology includes rectocele, a functional defect, and sphincter atrophy, a structural defect. Rectocele grading ranges from mild to large. Sphincter integrity involves evaluating the internal and external anal sphincters for tears, discontinuity, or fatty atrophy, which is crucial for patients with fecal incontinence. The spectrum of rectal intussusception ranges from mucosal to extra-anal rectal prolapse. Identifying the depth of invagination is key to surgical management. Note that prolapse is the term only if the rectum is visualized outside the anus. Pelvic floor dyssynergia is a paradox where the puborectalis contracts instead of relaxing during defecation, causing a paradoxical spasm. This mechanical blockade narrows the anorectal angle, leading to obstructed defecation and chronic constipation. A single maximal strain sequence can unmask cascading biomechanical failure across all 3 compartments simultaneously. The structured report checklist includes placing reference lines, evaluating the anorectal angle, and assessing all 3 compartments for pathologies like cystocele, uterine prolapse, enterocele, and rectal intussusception.